My name is John Spurtis, and on behalf of the UMKC Healthcare Institute for Innovations in Quality, I really want to welcome everybody to the QBIC Forum today. I know a lot more people will be coming in shortly. And just as a little bit of background, I want to describe a little bit about what HiIQ or the Healthcare Institute is seeking to accomplish. And what we are aware of is that every hospital in our community is evolving to be a learning healthcare system. And we now have sort of 5 primary goals of high value healthcare: improving patients' experience, improving their outcomes, lowering the costs, trying to ensure provider well-being, and to improve the equity and reduce disparities in healthcare. And each hospital is investing a lot of energy and effort into accomplishing the quintuple aim. And this is happening throughout the entire region. And so HiIQ is predicated on a vision that if we could work collaboratively and start to share strategies and successes and how we are overcoming barriers and making improvements, we can move to being an entire learning healthcare community. And towards that end, HiIQ has 3 major components that make up the infrastructure of our activities. One is trying to conduct regional quality improvement projects. And currently we have 2 ongoing projects. We hope to really settle on a third next year and begin to roll that out. And the 2 that are currently existing are trying to assist people dealing with opioid crisis in the ER in conjunction with the Missouri Hospital Association and their EPIC program. And the second is on trying to improve the transition of care from the inpatient to the outpatient setting for heart failure, with a focus on addressing social determinants of health. HiIQ also has a training program. The first iteration of that was really focused more on researchers in understanding implementation research. How do we think about changing healthcare, and how do we evaluate whether it's working or not? And this is evolving now to be a much broader educational program that we hope will be able to meet the needs of a lot of the providers in the community. And so we will be updating you on that over time. And then, of course, there are these community forums. And today's is about maternal health care and equity in maternal health care. And as background, I think it's really important to realize that the United States stands almost alone throughout the world in the fact that our maternal mortality rate is rising. This is a graph from 1990 to 2015 of most of the industrialized countries in the world, and they're all getting better. We are getting worse, and we are 2 to 3-fold worse in deaths per 100,000 live births than really all but a few third world countries. And this is just a national embarrassment. We also are almost unique with the gravity of the large racial and socioeconomic disparities in maternal mortality in the US. And Blacks are 4 times more likely to die than whites, American Indians and Alaskan Natives about 3-fold. I mean, we have huge problems here that we need to address. Interestingly, cardiovascular disease is the leading cause of maternal death. And it complicates only 4% of pregnancies, but is responsible for about 1/3 of deaths. And the CDC estimates that over 2/3 of these deaths are preventable. And a challenge is that we don't, as a medical profession, have a lot of understanding about the best structures and the best processes of care, or how to even risk stratify pregnant individuals with existing cardiovascular disease. And so we have to get more of a deep understanding in what's responsible for maternal fetal outcomes to improve care. And Later today, Karen Florio will be speaking, and it's been a privilege to work with her. She's a maternal fetal medicine specialist who's been passionate about this, and working with Anna Grudzinski has developed a cardio-obstetrics clinic at St. Luke's, and really brought to our attention the need to figure out from a researcher perspective, how can we better develop strategies to improve care? And about a month and a half ago, February 1st, the American Heart Association came out with a call for a proposal. And this is supposed to be a bold and ambitious series of projects. They're going to fund one network to study disparities in maternal infant health outcomes. And it's a remarkable opportunity. It's supposed to support 3 to 5 interwoven projects that will have a rapid and meaningful impact on reducing disparities in adverse maternal outcomes. And I'm very proud to say that an hour ago, we at Kansas City submitted a proposal for this. And I thought I would just share with you what we did. Now, it's going to be extremely competitive. I don't know how, what our chances are, and we should conservatively estimate they're not good, but it's such an exciting project. I wanted to share it with you. The first, led by Karen Florio and Anna Grudzinski, will be a national registry of 1,500 pregnant women with heart disease throughout the entire nation. And this is a picture of the sites that are going to be participating in this study. And they're going to collect detailed information on pregnant women with heart disease and what their care and what their outcomes are. And that alone is going to provide very unique and novel insights into how to identify risk among this overall high-risk population, but also what structures and processes of care are associated with the best outcomes. And we're taking a very broad view of outcomes: maternal adverse cardiovascular events, adverse pregnancy outcomes, adverse neonatal outcomes. And then at Harvard and Brigham and Women's Hospital, they have a rich cohort of women in the Boston area who they have detailed genetic and metabolomic basic science data about these women, and they've interwoven it with the machine learning artificial intelligence program to also integrate social determinants of health, comorbidities, and other things. And they're going to try and see, can we risk stratify outcomes in women with heart disease? And then they're going to validate their work in HOPE with additional elements being collected in HOPE about perceived racial discrimination and structural racism and other things of that sort. So we think that will be an exciting way to further improve the risk models that will come within HOPE. There's a very interesting program being developed by the Missouri Hospital Association to deal with the social determinants of health, particularly for urban women and for rural women. And they're trying to create an infrastructure of a clinical social model to leverage community-based resources that could be made available to women who have certain social determinants of health needs, to link them and follow their progress and be able to access already existing community resources that are not being well offered or aligned or integrated into care of these women. Our colleagues at KU are going to lead a very novel telehealth support program for pregnant American Indian and Alaska Native women. And this will be a regional, but also a national program trying to find support for these women who have very unique needs and cultural beliefs, and trying to really integrate all of that. And we're very excited about that. And then finally, there is going to be a study led by colleagues at Mass General in Boston that are going to try and help improve the recovery of women with cardiovascular disease and adverse pregnancy outcomes, to help them better lose weight, control blood pressure, etc. The grant is for $20 million over 4 years, and we've partnered with a lot of national organizations, the Preeclampsia Foundation, the March of Dimes, the American College of Black Cardiologists, trying to figure out ways that we can glean the insights from these projects and rapidly disseminate them nationally to have a meaningful impact. So with that as background, I'm very excited to go over the agenda today. So I've just given my spiel. Next will be Daniel Kennedy, the news vice president of BioNexus, and I'll turn it over to him for a minute. We'll then have a researcher perspective, Karen Florio, who really is the sort of guiding light of the HOPE registry, and she's going to be discussing maternal mortality in Missouri. We have Tracy Johnson. We're very appreciative to have her here talking about, from a clinician's perspective, how to be a health equity advocate. We have Mama Hakima Payne, who will be talking about Black liberation and anti-racism in perinatal care, followed by Wendy Stillwell from Blue Cross Blue Shield, who will be talking the role that payers play in addressing health equity. And then Stacy Farr will do the questions and answers. And I would be remiss if I didn't encourage and ask all of you to put any questions you have in the chat function, so we have your voices and your questions and we have them available. So at this point, I'd like to stop sharing and turn it over to Daniel. Thanks very much.
Hi, everyone. I'm Daniel Kennedy, the new Vice President at BioNexus KC. Thanks for the introduction, and it's great to see all the people on here that I've worked so closely with getting started, and then all the people that I'm definitely going to be meeting in the future. But I did want to take just a minute to introduce our newest grant series at BioNexus. Blue KC and BioNexus KC are once again partnering for a 2022 grant. This is one of our more productive community-based grant partnerships with local funding collaboratives for health equity in the KC region, most recently addressing food insecurity and health outcomes research. In the last 2 years, they've provided $400,000 in funding and is also one of the longest running community grant funds that BioNexus has had the honor of arbitrating. So on April 26th, which is next Tuesday, the Transforming KC Health Outcomes Research Grant will focus a $50,000 grant to be awarded in 2022 on specifically maternal and child health outcomes. We're looking forward to the very creative community-based proposals that we usually get, but this particular Transforming KC grant is particularly close to home. So thank you all for your attention, and I look forward to speaking with you about it if you want to talk further.
Thank you very, very much. And then I'd like to introduce Karen Florio. She's a maternal fetal medicine specialist and the director of the cardio obstetrics clinic at St. Luke's Hospital and an associate professor at UMKC. Karen?
Thanks, John. Let me just get my share. I have two screens here, so let me. Okay, so let me know. Do you guys see that? Okay.
Yeah, we see it.
Thumbs up. Great. Okay. So it's really an honor today to talk to you all about some of the work we do across the state in regards to maternal mortality. Actually, one of the honors of my career thus far is to serve as the Perinatal Mortality Review Board Committee Chair. And so I'm going to run you through a little bit about, of what we do here on a state level and what has really kind of sparked our questions about why this is happening. And so I think all of us watch the news. We are all very well aware that maternal mortality is a problem in this country. And the thing that really kind of gets to the core of me is that nobody is immune to this. This touches all age epochs, all races, all ethnicities, all cultural backgrounds. Rich or poor, it does not protect you. You know, there has been quite a few celebrities who have gone through this, and Chrissy Turlington is one of them who had a significant hemorrhage and now has a nonprofit looking to reduce maternal morbidity and mortality across the country. Athletes, I myself was a college athlete. I think this one is really tough for me because Serena Williams almost died of a pulmonary embolism, and it took her literally shaking her nurse to get the attention of her healthcare team to realize that something was wrong. One of my favorite athletes of all time, Miss Felix, had a preterm delivery, significant morbidity, and almost died of preeclampsia. So I think the thing that we need to realize is that this does affect us all. We all need to be paying attention. And the one I think that recently was incredibly sad was this amazingly talented, beautiful pediatrician at the University of Indiana who had the best healthcare in the country, and despite that, died from preeclampsia. And as Dr. Spertus so aptly pointed out, you know, if we consider maternal mortality as an indicator of a country's quality of healthcare, we know that this country is failing our women significantly. The United Nations millennial goal was to reduce maternal mortality by 75%, but as Dr. Spertus pointed out in his previous chart, from 2000 to 2015, we actually went in the opposite direction. And of all the OECD countries, as you can see here in this graph, America, or the United States, was the only one to report an increase. And I actually was looking, I gave this lecture to the University of South Florida recently. And that day I was looking at some new statistics, and I found that the most recent reporting in 2020, only ourselves and the Dominican Republic reported a rise. Every other country in the world either reported a plateau or a decrease. And so we have got to do better by every woman in this country. But I really want to take it down to the state level, because that's what is really important to us, right? We live in this state and we want to do better by our pregnant women. So I want to show you on a country level how bad Missouri is. Missouri has consistently ranked in the bottom 10 since they started reporting on maternal mortality. And despite all of our efforts, and I can tell you there are a lot, and you're going to hear some amazing speakers today. Dr. Johnson is the vice chair for the PAMR board. Mama Hakima has done amazing work in Kansas City with our African-American population. And despite all of our efforts, we are still in the bottom 10. I think Dr. Johnson and I, we joke a lot about, you know, the fact that we're worse than Mississippi. And actually, Tracy, I wanted to point out to you, we are worse than Mississippi because Mississippi isn't even on this list, right? So we have got to do something to change this trajectory. This is a public health crisis, and it is impacting the women of Missouri. So we all say we live in the show me state, like we're really proud of that, right? But despite plenty of documentation and press around maternal mortality, I'm not quite sure that our lawmakers really understand or see what's going on, because despite our very well-run PAMR, or our perinatal mortality board, you might also hear it called the MMRCs, which was recently recognized by the CDC for its innovation and organization, we are continuing to have these climbing rates. And since 2016, the maternal mortality rate in Missouri has risen by 42%. And that is not a small amount. So what is it that we can do, right? And I can tell you from being on this board that 2020, it has an even higher rise. And yes, a lot of that has to do with COVID, but I think we all know that COVID really exacerbated the disparities in healthcare, but also maternal mortality. And we're gonna see that soon. We're working through that now. So I think it's really important before we really dig down into the numbers, and I'm really here to give you guys a background. I think the most important part of this entire lecture today is really Dr. Johnson and Mama Hakima to talk about the disparities. But I think it's important from my perspective to give you a background of what's going on. And so in order to do that, we have to talk about the definitions. And I think the easiest way for me to tell you how we differentiate pregnancy-associated deaths versus pregnancy-related deaths is to think about it like this. If a patient was pregnant, and let's say 150 days after her delivery, because we do track it all the way 365 days postpartum. So 150 days after her delivery, she happens to be in a car accident and dies. Being pregnant didn't cause that car accident. So that is a pregnancy-associated death. The other very important term, and you're going to see this in a graphical representation, is the pregnancy-related deaths. And these are the ones we really want to focus on and where we see the significant disparities in it, Black and white outcomes. Pregnancy-related means, had the patient never been pregnant, would she still be alive? So did she have a cardiomyopathy that contributed to her death? And so these are the ones that we really try. They're all deaths are very important, and giving justice to these women is very important. But these are the ones where we really feel like we could impact. And so those are the ones I want to draw light to. So if you look at this graphical representation, you can see in Missouri, and again, this is our data from 2017, all of the deaths in 2017. We've been working on 18, and then we've been working on 19 and 20. You can see that the majority of the deaths in Missouri are pregnancy associated, but there is a quarter, more than a quarter, a third of the deaths that are pregnancy related. So we know how to define maternal mortality, which I think is really important. So let's talk briefly about how we capture this from a CDC standpoint. I think though, in order to do that, we need to take a trip back to 2003. When I first started med school, when it was first officially mandated to capture pregnancy on the death certificate. But it wasn't until 2016, actually, that every state implemented these changes. And because everybody staggered their implementation, there was wide variation in the reporting per state on deaths. And actually, the National Center for Health Statistics discontinued the publication of the national maternal mortality rate from 2007 to 2019. It was actually just the states that were doing that. So you're going to see all these different numbers. It was lower, it was higher. What is really important is that in 2019, when the data actually came out, from all the states reporting, we saw that there was an increase in overall deaths. And so some of the argument that we've had to face is that, oh, is this really a rise in deaths? Or is this just happen to be that we're capturing it and reporting? And I can tell you from being on the board that from 2018, when we were actually mandated by state law to be a maternal mortality board to present, we have continued to see a rise. So it may be that in that time from 2003 to 2016, when there was no reporting, yes, there might be a little bit of data capture issue there. But what is happening now is truly a public health crisis, and we need to address it. And so in order for us to all speak the same language, the CDC has put out what's called a Maria form. And I wanted to share this with you because I do think it's really important. And it's not important because we're capturing the data and we're analyzing. I think it's important because of what is on this sheet. What I want to point out here to you guys, and I think you can see I'm going to look this way because I have two screens, is that we not only talk about, was this a pregnancy related or pregnancy associated, but how complete was the documentation? And what were some underlying or contributing factors? And I think that is really important because that sets the stage for what Dr. Johnson and Mom Hakima are going to talk about. Was discrimination part of the reason this woman died? And I can tell you that is a difficult thing for a lot of boards to kind of tease out, and we have tools that we've been using for that. But I can tell you that recently we've seen a lot more of this in 2020, and it's very disheartening. So to focus on how we can change that structural racism is very important from a CDC standpoint, but also from a Missouri Mortality Review standpoint. And so I think, I talked about back in 2018 when we actually got the legislation around protecting us from being pulled into litigation suits because we're making recommendations on these deaths. At the same time, we were very lucky in Missouri to receive federal funding to support our maternal mortality efforts. Everybody who's on the board, aside from our adjudicator and our lead nurse, are volunteers because we believe in the cause and we spend our time doing this. But it's really important to know that federal funding is not endless, right? And so when you see reports on some of these maternal mortality funding bills that are out there, I do encourage you to call your legislators and support it because it does support the work that we're doing here. And so this slide specifically, I want to point out to you, it is all of the current MMRCs or the PAMR boards in the country. And I think what is really significant is if you look back in 2011, remember, we started reporting in 2003. So not until 2011 did states start forming these adjudication boards. And you can see the amazing progress that we've made from 2011 to current on how many states have put the effort forward to adjudicate these deaths, understand why they died, and start implementing change so that we can turn this around for our moms. So that's a little bit of background about what we do. You know, we meet quarterly. We adjudicate all the deaths in the state of Missouri, and we try to bring a little bit of justice to these women. What I think is really important and what a lot of people don't know is the timing of a lot of these deaths. I think there's a lot of focus on the pregnancy itself, right? A lot of people say, if we can just get her through, right? I particularly care for a lot of, or in particular care for a lot of women with cardiac disease. And these women have very high morbidity and mortality rates. And we hear that term kind of thrown around a lot. Oh, if we can just get her through the pregnancy. And that really doesn't do the patient any kind of service, because if you look here, the majority of deaths actually occur in the postpartum period. And so people can talk about the changing physiology of pregnancy, which actually does contribute to these deaths. But I think, again, what is going to be really important is Dr. Johnson and Mama Hakima's. Can you guys go ahead and mute?
Hey,
So
Pat, will you make me a co-host and I'll handle the muting.
yeah,
people.
that's great.
If
Sorry,
that's okay.
I'm not as I can't focus as well as Dr. Spurtis. So
No problem.
Shaylee, you actually are a co-host, and I'm also working on it.
okay,
But you are a co-host.
thanks, guys. I think it's really important to point out that it's in the postpartum period where many of these social determinants of health, where discrimination and structural racism really come into play. You know, just as an example, I can tell you that a lot of these women that we see who come in postpartum have multiple touch points in the ER, and they get dismissed, and they keep coming back. And so they know something is wrong. And if we can just change the perspective on the postpartum patient and maybe change the support around postpartum, which I think is going to be talked about, I think we can have a better outcome. And so the other thing I want to show you is the national data also coincides with the Missouri data. And again, this is just a graphical representation. I think this is going to be the most important slide for you guys today. And this is why I've been working so hard with Dr. Spurtis and Anna Grodzinski on this study, is that when we do these deaths and we adjudicate these deaths, we actually have an opportunity to say whether there was a chance to intervene. And in Missouri, I can tell you that 80% of the deaths have been deemed preventable. And what is really disheartening, and I think a really hard pill to swallow for a lot of people, is that the opportunity to intervene a lot of time falls on the provider. And so we have got to do better. And so as Dr. Spurtis pointed out, a lot of these deaths are due to cardiomyopathy or to cardiovascular disease. When I started my training in 2007, the traditional teaching was that preeclampsia and hemorrhage were the #1 causes of deaths. But now those have been surpassed by heart disease. And so I want to point out, and I know I'm running out of time here, so I want to be quick about this, that we actually can turn this around. It has been done. California is the only state that has been able to reduce their maternal mortality rate. And they did it by exactly what we're doing, digging into the causes of these deaths, recommending interventions, and then implementing those interventions on a public health forum. And so by doing this, by creating these bundles and protocols, these evidence-based protocols, they've been able to reduce their maternal mortality rate by 55%. And so one of the drivers in the country of reducing maternal mortality is the Alliance for Innovation on Maternal Health. And they've created these bundles, which I want to show you, that are really important when it comes to obstetrics care. And they are standardized, protocolized, mostly evidence-based. Some of them are based on expert opinion, ways to reduce harm. And so I just want to move ahead because I want to show you I think there's a question of do these things work? So we, as an example, we took the hypertension bundle at the state level and implemented it in different hospital systems. We had recommendations on reporting, meaning what are the metrics that you follow? Readiness, what do you need to have in your cart when it comes to hypertension as far as antihypertensives? And if when you protocolize those things and you expect it out of every nurse, every doctor, every ER physician, every community healthcare worker, because we did include them, we actually did a really good job at being able to bring down severe hypertension within the hour and having patients seen within a week postpartum. And so I want to just end there because I know we're running out of time. I wanted to give you some background on maternal mortality. We know this is a problem in this country. We know that our state is one of the worst. We are working on it. Some of the reasons are, number one reason is cardiovascular disease. But I think what is most important is to realize that there are significant disparities between Black and white maternal outcomes. And what can we do to change that? And so I really want to thank you for your time. These are just some resources if you are interested in going to the website. This is the Review to Action website. I would encourage you to go to this website because if you've never experienced an adjudication board, which I would say nobody on this panel has except for Tracy, you can actually watch a mock panel. So if you click on one of these links, you can get into a mock panel and see how these boards run. And you can see how we not only talk about the etiologies, but the opportunities for intervention and what we can do better in the future. And so I want to thank you for having me today, and I will take questions at the end. Sorry, I went a little bit over, Pat.
That was terrific, Karen. Thank you very, very much. I'm very pleased now to introduce Tracy Johnson, who is an assistant professor and the assistant program director in OB/GYN at University Health Lakewood and at University Health Health Sciences District. And thank you very much for taking the time to share with us your perspective as a clinician on being an advocate for health equity.
Thanks so much, Dr. Spartus. So I feel like Karen ushered me in perfectly, so we don't have to kind of rehash a lot of the other things. In general, I just wanted to say I don't have any disclosures and just jump right into health advocacy as it relates to maternal mortality. So I frequently use information from the Satcher Health Leadership Institute. This was developed and named from the Morehouse School of Medicine, but it came out of work that Dr. David Satcher was doing prior, who was the prior Surgeon General of the United States. They have this wonderful paradigm that I frequently will utilize. They have lots of videos, and just if you're interested in anything health equity and disparities related, this is a wonderful resource that you can use. If you look at their infographic, you'll see that they have just about everything you need on one page. Health equity is at the center, which is probably where it should always be. And it's driven by transformation of the health system in general, related to research and evaluation of all of your metrics and also leadership. Addressing mental and behavioral health are integral to the establishment of health equity. And so they have that there on the left. And then I think they rounded it out with policy and engagement, which is dependent on political determinants of health. We know that political determinants of health involve systemic processes, structural relationships, and the distribution of different resources and who administers power. And so these factors singularly and also in a group operate simultaneously in ways that mutually reinforce or influence one another. And they allow people to actually shape opportunities, whether people get those opportunities or don't get those opportunities. And I feel like in Kansas City in particular, and I would say also Missouri, that the political determinants of health create all of these social drivers, and they affect who has transportation, who has unsafe neighborhoods, and who has a lack of healthy food options. So I think that this slide basically sums up everything that we could talk about. And for that reason, we don't really need to even have a conversation. as far as how that relates to maternal morbidity and mortality, I feel like frequently we talk a lot about mortality because that's our end outcome that we're trying to prevent, but morbidity captures the rate of disease for a whole population and complication rates in a population. And so while we do focus a lot on mortality, I feel like frequently if we talk about morbidity first, we can actually prevent mortality. Lots of different groups, CMQCC in California, AIM, ACOG, SMFM, and lots of other bodies are looking at morbidity. And if you really get good at morbidity and decreasing that, then obviously that will bleed over into mortality. And then we won't have a PAMR board. I would love to not have a PAMR board or an MMRC looking at mortality because there are no deaths in Missouri. In doing so, I think I have maybe 5 quick tips that I believe can help us achieve health equity as it relates to maternal mortality. And I hope that you'll have some thoughts after we finish with this part. First and foremost, I do believe that equity and quality are hand in hand. If you do well at equity, you will do well at quality and vice versa. So number one, once you notice a difference in your populations, let's say you look at C-section rates in your population and you find that patients that are white have a C-section rate of 40%, and patients that are Black have a C-section rate of 25%. This is actually a data point that we looked at my institution, and I saw, I polled the group of providers, and they all were like, oh, okay. And so I find that interesting because that's also a disparity. Just because Black patients have, a 24-25% C-section rate and white patients have a 40%, that's still a disparity. It's still a difference in 2 groups. And so then you should look at all those metrics, look at all the factors that play into that and determine how to close that gap. And what we found was that we had many patients coming from fetal health center or other institutions that had anomalies. And we know that spina bifida happens to be less likely in African-American patients, and gastroschisis and things like that are a little bit less likely in African-American patients. And so that has skewed our data, but we looked to find out what that was, and we didn't accept that even though Black patients favored better in this specific metric, that doesn't mean that it's okay. Second, I think that generalizations could lead to actual harm of patients. And this is seen in lots of different parts of medicine. Dr. Florio alluded to that, but specifically as it relates to dermatology, we see that with the paucity of people of color that practice dermatology, we see a lot of generalizations in that population. And so there's been lots of documentation on different harmful things that have been done based on misunderstanding of skin textures or skin types. We see that in psych and how people access psych resources. And as it relates to maternal mortality, we see that as well. I would say that I don't see broad generalizations on the PAMR committee or MMRCs as it relates to race, but what we do see is bias as it relates to a demographic that a patient may belong to. For example, frequently various MMRCs around the country may say that people who are more affluent or have more education may have bias because we are not screening them appropriately. For instance, we might not necessarily screen them as appropriately for substance use disorder because they work in medicine or they're an attorney or they're a police officer. We might not necessarily ask them if they have suicide risk or homicide risk, if they are from a demographic social group that we think shouldn't have that much of an issue. And so those are things that we do see where generalizations about whether someone's okay or not okay do spill over into maternal mortality. And so we fail to screen those people appropriately and miss that encatchment or that touch point where we could have maybe obviated a negative outcome. Number 3, look at my time. Okay. Number 3, I think that we should interrogate whether a difference that we note between groups is a true risk factor versus bias. 2 examples I can give you quickly. One is anemia. We said maybe 8 to 10 years ago in the OBGYN community and SMFM, women's health in general, that African-American patients were found to more frequently have a hemoglobin of 10 to 11. And so even though in the first trimester, we might say anemia is 11.5, if a patient that was African-American came in at a hemoglobin of 10, oh, Black people have a little bit less blood count. And so that's okay. We tolerate that. That was interrogated. And a lot of people did some pretty robust research that said, guys, that's just our bias. Black people don't walk around with a decreased hemoglobin. That doesn't mean that they don't need to be treated. And so I will tell you, there must have been 15 different abstracts and research projects that were presented at SMFM just last year alone, debunking the fact that we are looking at something as a difference and we are including our bias in that, and it may not be true. The same as the case for C-sections, as I stated earlier, that a great example is the VBAC calculator, which we frequently use in obstetrics on the labor and delivery floor. This is basically what it looks like on an app on your phone. The old app, which was back in 2011, had age, ethnicity, and the ethnic groups were threefold: white, Black, and Hispanic. And do you know your BMI and what your BMI is, if you've had a vaginal delivery, and if you've had another reason for your C-section? These were meant for clinicians, and basically it spit you out of risk. So Dr. Tracy Johnson, I'm 42. No, I'm not pregnant, but I could put on there that I'm African-American. My BMI is maybe 30, and any prior vaginal delivery, yes, I've had one. And then my first reason for my C-section was because my baby was too big. This might spit me out a risk of maybe 20%. And I bet you wouldn't be shocked to know that the reason that that's driven down so far, meaning 20% chance of success for a vaginal delivery after having a cesarean, that rate is so low, 20%, because of the African-American part. And so people have debunked this as well, maybe 5 years of pretty robust research that says, hey, do we realize that just because we change one factor, African-American, do we realize that we're saying that African-American patients are less successful having a vaginal delivery? And have we thought about the fact that that might be provider specific and not necessarily because of the patient? Do we realize that we may be less likely to allow a patient to really try to have a vaginal delivery after cesarean if they're African-American? Have we then actually populated bias into an app? And are we actually utilizing that? I would say we are, because that's what we did. And then in 2022, actually, I think it was 2021, they changed it and removed race as part of this. But up until then, we used this calculator. And even to this day, you can look in the chart and see that people still use this calculator to decide whether a woman should have the opportunity to attempt a vaginal delivery. We, at my own institution at University Health, we looked at differences in why we were finding that certain women were not asking for pain medication. So we did a quick query to say, hey, after a cesarean, are people getting pain medication? And we found that people of certain demographic groups were not using as much medication. Is that a real risk factor, a real difference, or is it bias? And so we're currently looking at this, and Dr. Allison Stubbe at University of North Carolina has done lots of research on this as well. And what she found at UNC is that we don't ask women who don't speak English if they're having pain, because we don't want to get the interpreter. We don't ask women who are stoic or from certain religious groups if they're having pain, because they must not be having pain. And so for that reason, that actually translated into not a real risk factor or difference. It was actually bias. The last point, or actually the fourth point I'll make, is that we should definitely empower patients and ensure that patients have agency. This goes without saying. We shouldn't really have to write this on a slide. But the reason why I think we should is because frequently in our MMRCs and our PAMR committees and all of our boards, we say, oh, she was non-compliant. We write in the chart, she didn't take her medicine. We told her to come at this time and that time, and they did not do it. They are non-compliant. And the reason why I think it warrants a discussion is because what I feel like we should be saying, at least in advocacy work, is that if a patient isn't doing what you deem they should do, we should always just ask the question, why? Let's say a patient's not taking their insulin. Well, why is it? Is it because they don't have the medication, the money for medication? Is it because they fear needles? Is it because they don't believe that they actually need insulin? But why? If the person is bouncing from hospital to hospital or provider to provider, Maybe it's not necessarily that they're not compliant. Maybe because they're seeking something that you've not offered. Maybe it's because they don't actually trust what you're saying, or maybe it's because they're running from something. Maybe they don't quite understand that the services that you're providing are at this hospital and not that one. So bridging those gaps and actually meeting the patient where they are, it goes without saying, but I'll tell you, in our review and the work that we're doing at the state level, this is frequently something that we see where we just did not meet the patient where they were. The last thing I'll say also goes without saying, but I felt like it was prudent to just mention, formulate teams of stakeholders that can affect small incremental changes. Don't try to bite the entire elephant, as the saying says, how do you eat an elephant one bite at a time? So just take small incremental steps. Someone important said that. Oh, wait, his name is Dr. Don Berwick, who's the head of the IHI. And now with these small incremental steps that he started, actually has an entire coalition that everyone uses in the country. And so I think that making your team aware that we're trying to do small things at once, small things in a series of steps, actually keeps you from being overwhelmed and keeps your eye on the target. I think that's just about my time. I gave us a couple extra minutes. So at the end, we will talk about questions and feedback and comments. Thanks so much for your time, guys.
Thank you so very much, Dr. Johnson. The next speaker is Mama Hakima Payne. She's the CEO of Uzazi Village, and she'll be talking about Black liberation and anti-racism in perinatal care. Thank you so much for presenting.
If you are speaking, you might still be muted.
Thank you for that reminder. Thank you, everyone. Delighted to be here presenting to you today. I'm Hakima Payne, and I'm here to talk to you about Black liberation and anti-racism in perinatal care. I'm the founder and CEO of Uzazi Village, which is a nonprofit organization here in Kansas City that's devoted to building Afrocentric adjacent care systems in which Black people not only survive, but thrive. I'm going to be referencing the work of Dr. Donna Davis at New York University, who coined the term obstetrical racism. She states that obstetrical racism are the mechanisms and practices of subordination to which Black women and people's reproduction are subjected that track along histories of anti-Black racism. Clearly a lot of, sorry about that, going the wrong direction. A lot of our work here at Uzazi Village is certainly predicated on Black liberation, anti-racist theory, and womanist theory, Black womanist theory. And we take it as a given that systemic and personalized racism underlie a great deal of healthcare and are a big part of the problem. So I'm really grateful for the work of Dr. Davis, Dr. Scott. If you have time later, I suggest you click on the link there and watch their lectures. They explain this more in depth. But both of their work have given vocabulary to a lot of the phenomena I observed during the earlier days of my career when I was a labor and delivery nurse. Dr. Davis defines these 6 categories. The 7th I'll talk about in a minute, racial reconnaissance I'll talk about separately. But she describes and gives form to these 6 categories of racism that I found really helpful to place acts into these categories. So I'll just give a brief overview of them real quickly here. Diagnostic lapses might be oversights, although it can also come in the form of undertreatment as well as overtreatment. But racism in healthcare can absolutely express itself in diagnostic lapses. And I will say, as someone who's spent a career studying the manifestation of racism in healthcare, it occurs in absolutely mundane ways. It may not be at all obvious because it's simply the way we move and we're used to it. And if ever you find yourself saying, well, with this population, there's probably some bias and racism embedded beneath that statement. So it bears interrogation. Another way is neglect, dismissiveness, and disrespect. Again, something I observed a lot of when I did bedside nursing, that expresses itself in a lot of very common interaction in mundane ways. Intentionally causing pain. I saw a couple of forms of this, one in not treating pain or not taking pain seriously or not believing the pain rating that the patient gave, or just withholding pain medication. So not believing, not responding to pain, and also intentionally causing it. So doing things in a way that were actually more painful for the client. And I saw both of those things happen routinely. Coercion, I think coercion is incredibly common in healthcare when it comes to Black and Brown, BIPOC patients. Either they do what you want or what you expect, or there's a punishment to it. And so there's always that threat hanging over the client's head, and clients are often just routinely coerced into doing things or making choices they'd rather not make because of the implicit threat that goes with it. Ceremonies of degradation are an interesting phenomenon, but again, phenomenon I absolutely did observe. It usually involved bringing in other authorities in order to get clients to conform. So that might be psychiatry, that might be social work, that might even be security. But some other authority is brought in order to get the client to conform to the desired behavior. And then finally, out and out medical abuse can occur and often does occur. And racial reconnaissance would be the efforts made by Black or BIPOC patients to not experience the other six. So racial reconnaissance might include things like carefully selecting your hospital or your clinician, based on reports from other family and friends. So folks are seeking out how to get the best healthcare for themselves without encountering any of these or lessening the impact of these. So that's racial reconnaissance. So again, very grateful to Dr. Davis for creating these categories and making it easier for me to talk about it. So what we do at Uzazi Village is our own form of sort of racial reconnaissance around healthcare systems. And one of the ways we've done that, one of our models is an Afrocentric group prenatal care model that was designed to create safe and sacred spaces for people, childbearing persons of the African diaspora. So we've done that in a lot of ways. I'm going to show you a little ad that we created for our clinic. I'll come back to that at the end. But the goal in creating these Afrocentric care models was to improve the quality of care for Black maternal health and Black infant health um, by using these Black liberatory models of care. So I'm going to take this down for just a second so I can run the commercial. So I'll reshare my screen to bring that up. And it's about 45 seconds long. All right, I'll stop sharing and actually I'll go ahead and put my contact information back up while I talk briefly. I know I just have a couple minutes while I talk briefly. I would like, if you have questions, take them now because I'm going to leave as soon as I'm done speaking because I have a night class to teach. So my contact information is there. I will say that the features of our Afrocentric prenatal care model are that it's multidisciplinary. We try to bring all the clinicians, all the services under one roof so that it's one-stop shopping for the client. So that makes that convenient, and that includes mental health services. But we also include traditional ancestral practices. So we have an in-house herbalist that works very closely with our clients. I would say that's probably the favorite feature for most of our clients is the services of our herbalist. Of course, we have lactation, chiropractic, we have parenting education. The hallmark of our model is that it's a midwifery and doula-driven model. So the care providers in our clinic are midwives, and every client in our clinic is assigned a doula. So those are some of the major features. So I'll jump over here to chat real quick to see if I have any questions, which I don't see any. See a couple of compliments, thank you. How are women supported in regard to eating concerns of body image? Excellent question. That's of grave concern to us because our birthing persons are at risk for preterm birth, low birth weight babies. Their babies tend to be small even if they're full term. So we put a lot of focus on nutrition. However, we're still looking for a nutritionist to add to our staff, a dietitian or a nutritionist. All of our staff are African American, so it's been really difficult to find an African American dietitian or nutritionist, which points to another inequity. But that is an ongoing cause of concern, conversation. We want to integrate a whole lot more of nutrition education that's very culturally specific. So we need someone Black in there who's talking about how to prepare your greens in a way that's healthy. We need that specificity because that's what we're looking for. How can we support the work you're doing? Come over and see us. Let me give you a tour of our clinic, and we absolutely want folks to know what we're doing and what the broader implications of it are going to be for broader systems remains to be seen, but we want to show that a specific focus on cultural norms and Black ways of being and traditional and ancestral practices absolutely alter the way that Black folks interface with healthcare systems. Thank you.
Thank you very, very much for presenting. Really appreciate hearing your experiences and perspective. Our last speaker will be Wendy Stillwell, who's the Director of Community Health for Blue Cross Blue Shield of Kansas City, speaking from a payer perspective about the role they play in addressing health equity. Thank you so very much for taking the time to present today.
Good afternoon. I'm just trying real quick to figure out what happened here. Can everybody see my screen?
Yes, we sure can. Thank you so much.
Thank you. Well, good afternoon. I am Wendy Stillwell. I'm the new Director for Community Health from Blue Cross and Blue Shield of Kansas City. Originally, my colleague, Dana Middleton, was scheduled to be here. She's a health equity practitioner and unfortunately had a personal conflict that precluded her from being here. But I have to say, listening to the panelists that have come before me, I am nothing but humbled and impressed, grateful to have the chance to participate here. And on behalf of Blue Cross and Blue Shield, I would also say that being new to Blue Cross, I would say that I'm equally excited to learn and get to know some of you and collaborate and work in the near future. I would also say that the panelists before me have done a better job than I could have of establishing the importance and the framework of the crisis that we're in when it comes to maternal and infant health. I would only add that as a payer, we believe that it's, I realize my video's not on. We believe that it's important not only to address these preventable and unnecessary illness and death, but as a payer, it's also important for the overall health of our population. And I would be transparent and add to that is also going to be influencing overall total cost of care. We today have a lot of the panelists before me have talked about the health disparity when it comes to maternal health. And obviously we're looking at you know, those outcomes, but I think it's also important to look at healthcare disparity. When we, and those, I'm sorry, I'm like having a hard time looking at which screen it is that I'm looking at, I apologize. When we talk about those health disparities, I think it's important to look at the healthcare disparities. That's access to insurance, insurance coverage, access to healthcare, utilization of care, and quality. Usually when there is a health disparity, there is a healthcare disparity associated with it. So I think it's been touched on in the last 30 minutes about the importance of the social and economic factors of the SDOH that influences these outcomes. Health equity refers to those non-clinical factors that affects the outcomes in health. Obviously, we can look at health coverage, provider availability, the quality of care, stress, but I think it's also important to point out that those, and it's also been discussed and already set the stage of the broader social and economic factors, including structural and systemic racism and discrimination that play a role in shaping health and disparities in health. In maternal and infant health, I think this is specifically or especially important when you look at that intersection of race, gender, poverty, and other social factors that influence those outcomes. When you look at perinatal depression, preterm birth in African American women's and higher rates of mortality for Black infants. this is just a slice of the data, and I think it just highlights what has already been established, that we have a disparity in maternal mortality, not only nationally, but also regionally. I knew that we were ranked on the bottom 10. It's more sobering that we're now going down to 7. And I think that given that, and that Blue Cross is a large local payer, we certainly can play a role and should be at the table to helping address these disparities. So one of the target programs that Blue KC is embarking on, maternal and infant health, is definitely a strategic and priority for 2022. And we're going to be piloting a community health worker program that I'm very excited to be rolling out. We have our very first CHW starting next month. The goals of which are twofold: obviously addressing the social determinants of health. We are partnering with Mid-America Regional Council to help when we identify those social needs, to help them to help connect them to those community-based resources. We're going to be focused on the key performance indicators, or those key target measures that we're going to be looking at to see if we're successful, or that we're going to be tracking out as prenatal visits in their first trimester, postpartum depression screening, and well child visits, 0 to 15 months of age. We're starting this pilot with as an employer-based model with one of our clients who is located in the urban core and has racial and ethnically diverse employee base, and reflects a lot of these disparities that we've been talking about. But I think it's also important to notice, to highlight that though maternal and child health and the community health worker program are certainly target programs that we have for 2022, I think when you look at Blue Cross and the role that it plays, it is, those two are just part of the overall construct and our commitment to health equity. So obviously, again, as a payer, we are committed, or we have a responsibility of leadership and advocacy, and partnering with community organizations to increase our reach. To that end, we are partnering with the March of Dimes and are committing $150,000 towards group pregnancy centering support and network-wide implicit bias training for our staff and our providers. We're also going to be through the BioNexus, we're going to be awarding $50,000 grant for maternal and child health community-based clinical research. We also understand and value the role that data plays in this effort. To that end, we are actively working on a way to gather this information about our members, so that we can not only more accurately identify these gaps and these disparities, but also it'll guide our improvements efforts around it. We're also rolling out a social health referral platform that will help not only equip our own staff, but also our providers to better meet those needs, of those social needs when identified. Network adequacy. There's an opportunity to collect, we don't have that information right now, is collecting and gathering race and ethnicity for our providers to help our members match their preferences with providers that they feel more comfortable with. And so we're looking at how do we capture that information for our members. So again, I think this is just an overall picture of how maternal health is just part of our health equity health equity construct. So with that, I think that is all I have, and I'll take questions at the end.
Great. Well, thank you so much, Wendy. That was wonderful hearing about the Blue Cross and Blue Shield perspective on addressing health equity. At this time, I want to thank all of our tremendous speakers. This has been a really outstanding panel, I think, of just various perspectives. I mean, and I would encourage anyone at this point, to either come off of mute if you have a question for any of our panelists. Otherwise, you're also more than welcome to put any of your questions or comments in the chat. We did have, I saw one that had come up earlier from Kendra Wyatt, and I don't know if she wants to bring it up, but there was, she brought up really about moving the needle from paying for outcomes as opposed to fee for service. And there are some interesting, alternative payment models that have been done in certain either programs or states. For example, I know the Texas Medicaid program did an alternative payment model where they were testing bundling the payment of, excuse me, my phone, testing, paying bundling care for maternity care as well as some of the fetal outcomes as well. And, they did see in their program, for example, 5 days increased length for gestational age and 6 ounces increased for gestational weight. And so I think, there's others that are kind of around the nation testing out alternative payment models, but I would love to hear from any of our speakers, particularly from, Blue Cross and Blue Shield, if they've considered thinking about any bundled payments or any ways to think about paying for value versus fee for service and partnering with providers, or from any of our providers on the call, Dr. Florio or Johnson, in terms of your experience and on the provider side of what you think about bundling versus fee for service, or if Wendy wants, or if Kendra Wyatt would like to come off mute and talk a little further as well.
This is Wendy. I can certainly take a stab at it, and I would add that let's connect it offline if I am not, because again, I am new to Blue Cross, but I do know that we have a value-based care provider, and we have a patient care first program. I can tell you that at this point, we're evaluating all reimbursement models, and I think that this certainly does. I think what we'll learn from our community health program is certainly going to set the stage for what's to come in the next year. We already have some sort of reimbursement models for SDOH screening, but we can certainly look at how do we embed some of these other key clinical outcomes to that reimbursement model.
Wendy, this is Kendra Wyatt. I'll jump on to my my original question and just say welcome to Kansas City, and I'm so glad you're here. How we are paid directs our behavior, and what we're talking about here as a community is, number one, focusing everything around the woman herself and pregnant people and lifting up Black women specifically, and then building an entire system around that pregnant person. And today our reimbursement is facility centric, it's high intensity centric, and we really need multi-payer alignment. We need to stop thinking about things in terms of just Medicaid or commercial. We all live in this community. We want providers to see all types of payers. We do not want to become more segregated. And that has been my observation, is that the complexity of navigating reimbursement right now leads obstetric providers to either choose they are part of a system that is focused on Medicaid, whether that's the FQHC and the academic medical center, or focused only strictly on commercial payment. And that is more likely to be racially segregated. And that's not okay. I think we got to make it work for everybody. And there are models, specifically Tennessee has been doing bundles for years. And I would lift up the Nashville public school system. If we work with schools and their pregnant population, what they've done with Vanderbilt, we will move the needle. That is a team-based approach that honors midwives, birthing centers, hospitals, maternal fetal medicine, obstetricians, and everybody working on the same page to get women to the right level of care. Doulas, pelvic health, community health workers, really everybody all together. So we do know there's models there. And then just lastly, and then I'll step off stage here. We are the hometown of Cerner, and we need to be talking about what we can do to use contemporary high-tech standards for us to not be faxing information to each other. That is ridiculous. And I'm going to continue to advocate that we need a community-sponsored longitudinal health record that is owned by the woman and then is started for the baby at birth. And that all of us are contributing our data to that record owned by that person, not us, so that we can lift up self-determination and health literacy. So those are really broad points, but so happy Wendy's here. And the payer's behavior drives everything in terms of care delivery and what we do as providers.
I really appreciate that point, Kendra, and I couldn't agree with you more. I can tell you your comments resonate very deeply with me. I come from over 10 years on the provider side. So I'm looking forward to this opportunity, and I think we're setting the stage to be able to gather that information, to be able to modify how we structure not only reimbursement, but also our benefit structure for our members. And I can tell you that I'm grateful and proud that they're committing this, our first effort that I've been a part of with maternal and child health.
That's great. Okay. Does anyone else want to ask any questions? I'm going to scroll up. I think there was a little bit of conversation in the chat that might be worth bringing up, unless anyone else has a burning question. But one of the comments, that I think Dr. Florio and I were communicating about in the chat, but I think another thing that's interesting is to think about, we see what we're doing so poorly in the US and Missouri, and why. And so I think, the question I had kind of posed is really, when we look at US compared to other OECD countries, why are we seeing, what is wrong about the US other than well, many things, right? But I think, where can we start to move the needle? And so, for example, in the Commonwealth report that I shared in the chat, there's a number of differences that have been pointed out in the United States compared to these other OECD countries who are not performing nearly as poorly as we are. And, just some of the things that are observed for what the differences are, or like how the provider mix is laid out in terms of OBs and midwives, as well as both the supply of OBs and midwives is too low, but also things like parental leave and having paid family home or paid home visits. And I think when we're talking about especially health inequities, things like home visits, things that like parental leave, things that are really critical, especially for people who are at the lower levels of the socioeconomic status, we have to find ways so that we stop perpetuating and continuing these health inequities. And I think we have to think, bigger and more backed up in terms of what policy changes need to be happening and where do we need to be advocating and for what. But I'll stop talking about it, and I would love to have any of our providers on the call or anyone who would like to come off and just kind of hear from your perspective what you see as some of the main other drivers, or what we can do collectively to help move the needle, knowing the things that we have wrong in the United States.
Stacey, I'll just come off real quick and just say I agree with everything you said. I feel like the system is broken. I know that we've all kind of alluded to that, but it's broken. When we have to have a doula, and I 100% believe in doulas. I think doulas are wonderful. I want every patient to have a doula. But what we're saying when we say we need a doula to decrease poor outcomes, to increase birth weight, to decrease preterm birth, to increase breastfeeding, all the things, touchy-feely things that we want. When we say we need a doula to do that, what we're in effect saying is we need an interpreter for to bridge the gap between a patient and a provider, because we're not able to just speak to them in a way that they either trust what we're saying, believe what we're saying, or in effect do whatever it is, management treatment that we recommend. And so when we say that doulas literally wipe away the disparities, that's what we're saying, is we're just flashing the light on the fact that the system is broken. So I think that just owning that and figuring out where we have lost ourselves, where we are talking at patients and not talking with patients, that's where we start. And it starts from the base. I mean, you can't get in. We know that everyone in this country that has Medicaid knows that if you are pregnant, you can get Medicaid. And yet patients don't call until their Medicaid card comes in. Their Medicaid card comes in at 16 weeks and they've already had 3 anomalies because their diabetes isn't controlled. And they could have called from the beginning, but the front staff says, I need your card. And it's broken from the beginning. Karen, what do you think? I know you came off of mute.
I agree with you wholeheartedly. I think Tracy and I have this conversation constantly. I think that with all diseases, recognition is important, right? So recognizing that we have a problem. And one of the things that Tracy and I are working on at the state level is assessing whether that is actually happening in this state. I will give you an example. We, on our maternal mortality board, decided to put out a PSA on one of the easiest things that you could implement to reduce associated mortality, which was car accidents. And so we said, okay, we're going to do this. And we came back 9 months later and our team was like, okay, we did it. And we were like, oh, so where did it land? And so that got us thinking, well, if we didn't see it, who else didn't see it? Then who else doesn't know about this? Who is not reading our report from the Maternal Mortality Review Committee that this is a problem, right? I think that recognizing that it's a problem, getting it out into the open, getting lay public to understand that this is an issue, and then we can work from there, right? And I agree with you, Tracy. I think things are lost in translation. Yesterday, I was on a call with the New Hampshire Maternal Mortality Board, and they are a newer maternal mortality board, and we were talking about a case. And I was kind of guiding them because we do this now. And it was really hard for the providers to swallow that the recommendations we made were focused on providers' intervention and recognition. It was a bit uncomfortable. And so to recognize there's a problem, to accept that we are part of that problem, I think is a great first step.
Wonderful. Anyone on the line who would like to come off mute and have a comment or question? I'm going to search the chat as well.
So I have to run because I have a laboring patient. So I really am so honored to be here. Thank you so much. And I know that Tracy and I share a brain, so she can answer any questions that I am not here for.
Thank you so much, Karen.
Thanks so much, Karen.
There's a couple questions. One is from John Carney.
Yeah, thank you. I'd just like to echo what you've all said over and over again. This is probably the biggest issue I think we have to face in healthcare right now. And what I've not heard a lot about, I was very pleased to see earlier the mention of political determinants of health. And I'm going to volunteer because I'm a white guy, an old white guy. I think we're the problem. And I think until power structures are challenged and women speak up, and particularly African-American women who have voices, who've not been heard, are given a chance to grab the microphone and speak the truth to power, we're going to be in this situation for a long, long time. So I think this is a moral imperative. I think we've got to come up with structures that sees the accountability and the responsibility and place it where it needs to be. And we're all in. I'm ready to help in any way I can, but I think our organization and those that are represented here, we really have to be truthfully and brutally honest about, we just don't care as a society for the problem, and we have to. And I'm pleased that we're, and Kendra's point earlier about we got to put money in it. That's the way the American system works. It has to be dollars and cents and money, because that's what drives our system. So I want to, congratulate everybody for stepping up and doing this, and for the folks at St. Luke's and UMKC and the other folks that are on this, and all of you who are in the trenches every single day. It's a national embarrassment. It's more than that. It's a national shame, and we've got to do something about it.
Thank you so much for your words, John.
But John, this is John Spurtis. I want to say that yes, power structures have to change, but I don't think we really want to wait, generations for that to happen. And I do think Kansas City has a very unique opportunity the resources you've heard today, Blue Cross Blue Shield's commitment, I'm sure the other payers' commitment, the providers who participated, Usazi Village. I think we need to think about really radical and dramatic ways to make a change in the next 2 years, the next year. Start really working and thinking about how could we create a new model of care that will address this. And clearly that this is a huge problem. It's one that we're all aware of. A lot of us are working very hard on thinking of novel strategies, but Kansas City could be a remarkable wet lab for figuring out new strategies, new approaches, new ways of patient empowerment and provider awareness, and we should be doing it. I think just waiting for the current leadership to evolve and change is just too long a timeline.
Yeah, I agree with you, John. But I think, and I think that Kansas City has a history of doing that. If it's not good for the children, but that was 20 years ago we did it. It's always the question about how should we behave. So I think it's possible. I just think we've got to make sure that the right people are in the room in order for us to be able to affect the change that needs to happen. And we've got to have some demonstration by those in power and you're one of those. St. Luke's is a huge system that addresses this issue, as are many of the others that are represented.
Not as well as we could. We have a lot of opportunities to improve. I think.
I know, but we're getting there. I think it's a message though that we've got to make sure that other people are brought to the table, and we're trying to explore ideas in our organization too about how to make that happen. So I applaud the efforts here, and I didn't want to make it sound like a downer, Debbie Downer kind of thing, but I think there's good possibility for us to be able to do something like you say in the next 2 to 5 years. Thank you.
And then Dr. Johnson, were you going to say something else to that effect? I know you were.
All I was going to say is I was going to thank John for his words, but I was also just going to say that I do think it's all of our problem. I do acknowledge what you're saying. I know where you're coming from, not personally, but I can empathize. But I think that as a clinician, I will say that I have a big project right now looking at social determinants of health in University Health. We have applied for grants. We don't get the grants. So it's like people say, Dr. Spurtis just put in for a grant today, and I think they're going to get it. But if they don't, do we really care? I think we do. But someone asked me on a talk that I gave about 2 months ago, Dr. Johnson, if you could do anything in the world, what would you do? And I would say exactly what I'm doing, number one. And they'd say, well, what do you need to do it better? I need Elon Musk money. I promise I could put it to good use and we would see that number fall, John. We would see it fall. But we got to beg and plead for small tokens to move the needle. So I just don't think it should be that hard when we're literally boots on the ground telling people this is what we see, this is what we need, this is what we want to do. And we have to literally write grants like Dr. Spurtis and Dr. Florio and Anna Grzinski just got through doing. It takes 5 years to write those grants, for some people, and then you don't get it and you just start over. So I'm just tired of being the hamster on the wheel, having to beg for $2 to do something that I know will affect change. So I don't know where we fix that, but that's just real talk. That's what we're doing right now.
Yeah, no, you're bringing up real issues. It's the need for it at all levels, and thinking of this, we're working so downstream, but also we've got to start moving this upstream, right, to make the bigger impact so that it's
Yeah.
not having providers and researchers beg for, hey, we want to do a little program, not little, but you know what I mean, but some
Yeah.
program so we can help get, a lactation consultant into a woman's home so that
That's
she can,
right.
things like that. So, I think this, I know we are at time, I want to be respectful of everyone's time, but I just, I do think that forums like this are really great for getting our community kind of thinking together how we can start to collectively make a larger impact together, ways we can innovate through, and with the payers, with the hospital systems, with the community organizations, with researchers, if we can find more, new and novel ways to make a large impact here, that's, even better. And anyone that has any comments, ideas, questions, feel free to reach out to any of us or the speakers. And also just, I just want to thank all of the speakers. This was a tremendously fabulous session in terms of highlighting where we're at, but also getting us all to think a little more creatively about how we can collectively work together to make better outcomes for our community. So thank you, everyone. Thank you to BioNexus for helping support and QVIC and our forums. And I see Pat's off mute, so maybe she's going to tell us about our next forum.
Yeah, our next forum, May 19th, Behavioral Health, Healthcare's Third Rail. So put that on your calendars. We'll start sending invitations out probably next week. And thank you again to all of our speakers. You all were wonderful to coordinate with and exchange communications with. And as Stacy said, great gratitude to our partner in BioNexus.